Hello and welcome to the presentation on skin integrity and wound care. Your competency is to provide care for patients with infection. Please familiarize yourselves with the learning objectives for this unit. If you're not familiar with the skin layers or characteristics of normal skin, please review this in your Craven text. The skin's purpose is for protecting from physical and chemical injury and infection, thermoregulation of body temperature by vasoconstriction and vasodilation, which causes shivering and sweating to control temperature, sensation through nerves contained in the skin, metabolism of vitamin D from the sun's rays, and communication through facial expression and physical appearance. Skin turgor normally decreases with age and abnormally decreases with dehydration. A cultural consideration to remember is that with darkly pigmented skin, it may be more difficult to notice stage 1 ulcers and deep tissue injuries. Also, cultural healing rituals and traditions vary and may cause bruising and other marks. The skin needs adequate blood flow to be healthy and viable. Circulatory diseases result in skin with abnormal color, texture, thickness, moisture, temperature, or integrity. For example, ulcers from venous insufficiency, arterial insufficiency, or peripheral neuropathy can be difficult to heal due to poor circulation. A well-balanced diet promotes healthy skin. Nutrient deficiencies can cause dry, dull, flaky skin and hair, abnormal pigmentation of the skin. Exposure to moisture can cause breakdown, yeast in the skin folds, or rashes. Histamine release causes allergic reaction and skin inflammation, pain, itching, redness, and blistering. Chronic exposure can cause thickening, scaling, and increased pigmentation. Infections of the skin can be bacterial, fungal, or viral, and are most commonly streptococcal or staphylococcal organisms. Necrotizing fasciitis is a medical emergency caused by commonly occurring group A strep that usually causes only mild skin infections, but with necrotizing fasciitis, the infection progresses very, very rapidly and can be fatal if not treated. Viral skin infections include warts and herpes simplex virus. Yeast skin infections include yeast, with candida infections being common. Malignant or non-malignant growths, lesions, can cause abnormal skin growth rate. Systemic diseases such as inflammatory bowel disease can cause perineal breakdown, and diabetes can cause ulcers or poor wound healing. Burns result from exposure to heat, electricity, caustic chemicals, or radiation. The rule of nines is a standardized method used to quickly assess how much body surface area has been burned on a patient. But it's important to note that this rule is only applied to partial thickness or second degree and full thickness or third degree burns. Friction is when two surfaces rub together and cause abrasions. Shear, on the other hand, is when the tissue layers move over each other, causing blood vessels to stretch as they pass through the subcutaneous tissue. Capillaries and underlying tissue are then stretched and torn, which increases the risk of ulcer formation. It's also important to know that low intensity pressure for long periods of time or high intensity pressure for short periods of time can cause pressure injuries, especially for those patients that are at risk. Pressure injuries are related to unrelieved pressure. They most often occur over bony prominences as a result of pressure in combination with friction and shear. They are caused by immobility and medical devices such as oxygen tubing. Risk factors include decreased mobility, increased sensory perception, fecal or urinary incontinence, and poor nutrition. Contributing factors include pressure on the tissue, making it unable to receive oxygen and nutrients, and to eliminate waste via the blood related to poor or impaired circulation to the area. So how do pressure ulcers develop? 1. Pressure intensity exceeds the normal capillary pressure, which is enough to close a capillary, which leads to tissue ischemia. Then, pressure duration, like we said, low pressure for a long period or high pressure for a short period. And then the third factor you need is tissue tolerance. This is the tissue's ability to endure pressure, and it depends on the integrity of the tissue and the supporting structures, as well as the friction, shear, and moisture it's exposed to. Also, the underlying skin structure and how it can redistribute the pressure. So reactive hyperemia is blanchable, and if pressure is relieved in a short time, the capillaries dilate, but blanchable hyperemia, there's no tissue loss if the pressure is relieved. If it's non-blanchable hyperemia or redness, this indicates tissue damage, and this is the first stage of pressure ulcer development, but it still may be reversible if pressure is relieved and tissue is protected. Blanching does not occur in patients with dark skin, so keep that in mind. You need to look for color change. The skin might be lighter and not intact, or it may be cooler. And then you want to compare it to surrounding skin. Look for edema or a purple-blue color. Ulcers are classified as stage 1, 2, 3, 4, unstageable, deep tissue injury, or mucosal. Stage 1 is non-blanchable and injury can be reversed. Stage 2 is a partial thickness loss, such as blistered skin. Stage 3 is a full thickness loss and often goes to the subacute tissue. And then stage 4 goes even deeper and involves damage to muscle, bone, or other structures. Unstageable wounds are covered with slough or eschar, which is scabby tissue, and the wound bed is not visible. Deep tissue injuries look like a purple bruise and often get worse before they get better. We don't know, just looking at it, how bad it's going to get. Sometimes they don't get bad at all, and sometimes they develop into really bad tunneling kind of wounds. Be sure to measure any wounds, including the length, width, and depth, and just know that some wounds might tunnel or go under the skin, so you got to measure underneath of there too. And then pay close attention to each type and be sure you have a good understanding of how to classify wounds. You will need to know this for your nursing career, but you'll also need to know it for the exam. These pictures of what pressure injuries look like based on their classifications are shown here. Be able to assess and classify the various stages of pressure wounds. So on to the phases of injury healing. The inflammatory phase lasts up to 3 days. Histamine secreted, which leads to redness, swelling, and a moderate amount of serous exudate due to vasodilation. This process is beneficial and there's no need to try to cool the tissues unless swelling occurs in a closed compartment, such as the neck or the ankle. Leukocytes move to the wound to ingest bacteria. They clean the wound and release growth factor. This is called phagocytosis. So in a clean wound, the inflammatory phase is established better, so be sure to clean the wound bed. If it's got a bunch of yuck in it, you need to kind of get that out of there. Too much inflammation can affect availability of nutrients to cells. Hemostasis is a cessation of bleeding, and white blood cells are brought to the site. Epithelialization works best in a moist environment. Epidermal cells migrate from the wound edges across the wound base and continue to cover the wound bed until the number of cellular levels in the cells, in the epidermis, is the same thickness as normal, healthy epidermis. In full thickness wounds, collagen is formed and the wound contracts. During proliferation, the wound fills with granulation tissue. It contracts and resurfaces through epithelialization, which pulls the wound inward. Partial thickness wounds will appear beefy red and granular. Granulation tissue contains the capillary network, so it's fragile and bleeds easily. So just remember this: if it gets scraped or scuffed while it's healing, it's going to bleed and it's going to be starting all over again. Remodeling or maturation is the final stage of healing and starts at about a week post-injury and sometimes takes place for more than a year, actually. Collagen continues to reorganize and gain strength, but it's not usually as strong as previous tissue. Scar tissue may form, and this contains fewer pigmented cells and has a lighter color than normal skin. And then just know that dark-skinned individuals may have a more highly pigmented scar tissue. So in wound healing, through primary intention, the wound edges are approximated or pulled together. Granulation tissue is not visible, and there's usually minimal scarring, and infection risk is lower, as long as the wound was clean to start with. So an example of this would be a surgical incision pulled together and sutured in place. In wound healing through secondary intention, the wound edges are not approximated, so healing occurs gradually through layers of granulation tissue. An example is pressure ulcers and burns. There's a longer repair time, greater scarring, and an increased risk of infection due to colonization with organisms. So bacteria might move in, being as it's not sealed up and that skin doesn't have its protective layer. In wound healing through tertiary intention, there's a delayed primary closure or secondary suture, which is a delay between injury and wound closure. The wound is initially cleaned, debrided, and observed for typically 4 or 5 days before closure to watch for infection or swelling. Note here that the wound is purposely left open. So an example of this is the healing of wounds by the use of tissue grafts or performing fasciotomies, which is a cut through the muscle fascia to let muscle tissues swell. This slide lists factors that have a direct impact on wound healing. One thing to note is that elevated blood sugars have a negative effect on wound healing, both by prolonging the healing time and increasing the risk of infection. Smoking leads to vasoconstriction also, which negatively affects wound healing, as well as by decreasing the oxygen supply to the wound. So here's some complications of wound healing. Hemorrhage is excessive bleeding. So what risk factors could increase hemorrhage risk? If you have a large vessel severed, the patient maybe is on anticoagulants, has a bleeding disorder, or a clotting factor deficiency. What does internal bleeding look like? Usually you see a hematoma, which is a collection of blood beneath the tissue. There's usually distension and swelling. Not always. Sometimes it's inside where you can't see it. You want to look for a change in the type and the amount of drainage. Look for signs of hypovolemic shock, and know that the risk is greatest the first 48 hours after surgery. Severe low back pain can signify a retroperitoneal bleed or bleeding into the peritoneum, and this is one where a lot of times you won't see signs of bleeding, but you'll see a drop in blood pressure. You'll see the patient looks pale and pasty. They're having this severe back pain, and that is a medical emergency because they can bleed very quickly and actually die from that. So they'll look at a CAT scan to see that kind of bleeding. And then external bleeding, you look at obvious signs of bleeding. Multiple dressing changes. Are there pools of blood beneath the patient? You want to observe closely. The greatest risk for this is 24 to 48 hours after surgery. And then if there's an emergency and you have a significant amount of bleeding, you want to apply pressure and monitor vital signs while the physician or provider is called. Wound infection is the second most common infection. Nosocomial infection is the first. And wounds with greater than 100,000 organisms per gram of tissue are infected. Patients will have some positive cultures which result from non-infective resident bacteria in the wound, so it's important to see that 100,000 plus organisms to have your diagnosis of infection. Chances of wound infections are greater with dead or necrotic tissue, if there's foreign bodies near the wound, or if the blood supply and local tissue defenses are reduced. So what do we call the different types of wound drainage? Excuse me. Serous drainage is the clear portion of the blood and is watery. So example of this is a blister from a burn. Purulent drainage is thick. It can be yellow, green, or brown, and odor is often present. So an infected wound is an example of that. Sanguineous drainage is fresh bleeding and is bright red and thicker than serous drainage. An example here is drainage from a new surgical wound or immediate output after surgery. And then serosanguinous drainage is clear with blood streaks. It looks a little like Kool-Aid and it's thin. So an example of this is what might come out of a surgical incision. Dehiscence is a total or partial separation of the wound edges, but the subcu layer is intact. This usually happens in 3 to 14 days of injury before the collagen formation is complete, because remember it's weaker at that time. Risk factors include obesity, poor nutritional status, increased stress on the surgical area, So for example, female open heart patients wear bras when they get up to prevent their breasts from pulling the incision apart, which would be a form of dehiscence. Dehiscence is more common in abdominal surgical wounds and can be minimized by giving pillows or folded blankets to use for support when coughing or getting up. So this is not a medical emergency, but you do need to notify the provider and protect the open areas with saline moistened gauze until a wound treatment plan is developed. Evisceration is a protrusion of viscera or abdominal organs or intestines through an abdominal wound opening. Risk factors for this include obesity, poor nutrition, multiple traumas, failure of suturing, excessive coughing, vomiting, or dehydration. So this is a medical emergency. Place a patient in a supine position with the knees bent because this reduces pressure on the abdomen. Minimize their activity and cover the exposed area with saline moistened gauze and a dressing. And you need to call a provider immediately for this one. And then lastly, a fistula is an abnormal tube-like passageway between two organs or an organ in the outside of the body. So an example here is the anorectal fistula or an AV fistula, which is used for dialysis, and that's actually a surgically created fistula. Please watch the wound care and the nursing process presentation for applying the nursing process to wound management, and that will be a separate video, and that's all for this presentation. Thanks for watching.